Hi, my name's Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK. And I'm also a consultant in private practice. Now, if you've joined our Monday Facebook Lives before, you'll know that this is a great opportunity to share some interesting case studies, talk about some interesting things I've seen in the clinic, and importantly, really just to share some interesting information so that patients with the less usual pathologies might get picked up, but also importantly to share some rehab tips and tricks. So we kind of vary it around every Monday in terms of what's come up in my clinic, things that I think will be useful to share with you, but also importantly to kind of highlight some less usual presentations so that more patients might get picked up earlier in the process, which can have a big influence on their outcomes. But don't forget, hi to everybody that's joining us, but don't forget this is also your forum. So if there are some key patient groups that you're having difficulties with, or some specific conditions you'd like to know more about, or how I treat them, or the things I find useful, then please don't hesitate to share that with us on the Clinical Edge public Facebook page, and I'll look at covering those in a future Facebook Live. We've still got some outstanding subjects that questions have been raised in some of the previous Facebook Lives that I haven't got to yet, some vascular things that I definitely am going to cover in the next few weeks. But tonight I've just popped on to share a quick, interesting case study that really got me thinking and really highlighted how sometimes it can be very easy to kind of compartmentalize things according to our biopsychosocial model, but how we can never stop being vigilant. So the lady I want to share with you tonight was a 53-year-old lady who again I saw on a video clinic because still not doing much face-to-face other than urgents. And this lady had obviously been having a fairly difficult time. She had her own business that she'd just started before COVID. She was clearly very stressed because the lockdown was having a big impact on her business. She was very overweight, doesn't exercise regularly, by her own admissions isn't eating well. She knows she needs to lose weight, but she's eating fast food and takeaways and getting take-ins from all these amazing delivery services and basically not looking after herself very well. Now, she also says that she's having some problems hormonal-wise. She has been to the doctor. He's thinking about putting her on HRT. But generally she talks about that she's finding life pretty tough at the moment, and to top it off, she's now developed right shoulder pain. Now, she tells me that she had a subacromial decompression about 8 years ago, and the pain that she's getting now is very, very different. She doesn't feel like it's anything like the pain that she had to have her surgery for, but she's concerned because it often keeps her awake at night. She takes medication like paracetamol in an effort to get to sleep, and sometimes that helps, but ostensibly no change in position, no support of the arm makes any difference at all. When I ask her about the activities that cause her any particular problems, she's not really able to identify anything. She can't give me a clear list of movements or activities or things that she does that make the pain worse. And in fact, she tells me that she actually has really good range of movement. She does tell me that she had a whiplash injury many years ago and has had some intermittent neck pain, but actually mainly on the left side, not on the right. Now, already there's a few things that aren't fitting. There doesn't seem to be any positional pattern to this lady's pain, but where is her pain? Well, when I ask her about where her pain is, it's very much over the trapezius, the suprascapular fossa, and her posterior shoulder and scapular region. Now, when I ask her to localize it, she really struggles. It's poorly localized, it's deep, it's a kind of really gnawing ache, can be there for 1 hour up to 5 hours. Got some amazing people here tonight. 1 hour up to 5 hours. And again, she struggles to find anything that really gives her any relief. So I don't know if any of you are thinking already. I haven't looked at the chat. So I've given you some clues already about one, it's poorly localized pain. It's in the right shoulder. It's over this suprascapular and scapular region, a little bit into her upper traps, but she can't really localize it. When I look at her, she's got full range of movement. If I resist her, nothing reproduces her pain. If I look at her neck movement, she's a little bit stiff to the left. If I palpate the anterior pillar, she's a little bit stiff and tender on the left side, but nothing really comparable on the right side. So clearly, she's got more or less full range of movement in her neck. Palpation isn't fitting with that right-sided pain. Neck movements don't change her pain. And when I ask her about aggravating and easing factors, there's no clear pattern. Now, all these things should immediately make you suspicious. So what are the other things that we need to think about in somebody like this? Well, if we look at other things that can refer into the right shoulder and that might be relevant for this lady, one of the things that will refer into the shoulder in terms of viscera is the gallbladder. Now, if you look at people who are at risk of having problems with their gallbladder, females are definitely more at risk than men. Over 40, the risk becomes greater. Obesity has a big link with gallbladder problems, but also fair skin. So if you like the 4F, so this lady's fair, she's fat, she's 40, and as I say, she's female. So clearly she's got a tick box on all those 4 different things. Now, there's some other things that we can actually ask her to help drill down and see whether this is relevant. So immediately I need to have some other questions at my behest to rule those things in or out. And you would think that if you were thinking of left-sided shoulder pain and a cardiac issue, that you'd ask about exertion. And again, so we need to look at similar things in terms of the gallbladder. So one of the easiest things to ask is what happens when you've eaten a meal. Now, remember, this lady, by her own admission, is not eating very well. And no great surprise, she says that when she's eaten a meal, particularly if she's had things like hamburgers or anything fatty, that her pain in her shoulder does seem to be worse. Now, she hadn't really made that link until I asked her. And she says that she certainly has a worse night's sleep when she's had a particularly greasy meal. So that's the first thing. Now, another question that we wouldn't necessarily think of asking as physiotherapists or healthcare professionals is about her stools. So about what happens when she goes to the toilet and whether or not her stools float in the water. Now, why on earth am I asking that? Well, stools can float just because of more gas. So if you eat lots of beans or things that make you a bit windy, then obviously that can be a reason that they float. But also it can be associated with high fat content. Now remember, all these things are only relevant in conjunction with the other things that aren't fitting with a musculoskeletal problem. So again, when I look at the other things that you might need to consider in terms of patients who could have high fat content in their stools, it's most highly associated with things like lactose intolerance, Crohn's, celiac disease, pancreatitis, irritable bowel syndrome, so all those sorts of things. But I've got a lady who basically, her stools float, she gets worse right pain after her meals, and it's worse at night. So we've got a lot of things, as well as all those risk factors, that's stacking up the evidence in terms of perhaps the gallbladder is the cause of her pain. Objectively, none of my clinical testing is reproducing her pain. And in terms of a cervical spine, similarly, there's nothing that fits, if you like, that supports any kind of local musculoskeletal issue. Now, again, you can think that the patient might think it's a bit weird asking about those things, but patients aren't daft, and often they've kind of thought of some of these things. And there's some other things that can make patients more at risk of developing problems with their gallbladder. There's no doubt that if patients are having high dose estrogen therapy, that can be a real factor. So it's important as ever to know about any other medications that are on. Patients that are on the combined pill in their early 40s again have a higher risk of gallbladder issues. And again, those populations we talked about in terms of Crohn's and celiacs again have a higher risk of gallbladder issues. So those things in a history with right shoulder pain that's not fitting a musculoskeletal picture, just something to consider in terms of your differential diagnosis. Now, the other thing to be aware of is cirrhosis. The liver itself can refer pain into the shoulder. Interestingly, often the pain referred to the shoulder when the liver's involved is because of irritation of the phrenic nerve via the diaphragm, and often those patients will get some association with deep breaths and stuff. But I'll look at other viscera perhaps in a future Facebook Live. Tonight it's all about the gallbladder. Now, as well as cirrhosis, there's a couple of other things to be aware of. There's an antibiotic known as ceftriaxone. It's also known as rosapine, which is its kind of it's what's its name? I'll type out the spelling of it. To be honest, when you look at patients who have this antibiotic, generally it's for bacterial infections, so quite serious things like E. coli, meningitis, but it can be used for resistant urinary tract infections, it can be used for ear infections, and it can be used for pelvic inflammatory disease. So again, if patients have had some sort of infection in the recent past and have had that particular antibiotic, that does seem to be associated as a risk factor because of how it affects biliary function. So just some interesting things really in terms of somebody comes to you, we've talked a lot in the Facebook Lives about when, oh, thank you very much for spelling that. That's awesome. So we've talked a lot about the importance of when features don't fit, don't ignore it. Now, for me, I don't do a lot of systems analysis. This lady's on a video conference. What else can I ask her? I've obviously got to ask her whether she's got any right upper quadrant pain to kind of complete my story. But interestingly, when you look at the onset of gallbladder problems, and when we talk about gallbladder problems, we can just have cholecystitis in terms of inflammation. We can have actual gallstones, which can be an acute emergency of people in lots of pain as one starts to pass through your system. And also, obviously, you can have gallbladder cancer, but often that's associated with more systemic things in terms of night sweats and weight loss, which this lady didn't have. But the bottom line is, it's how we build that picture. So the key thing for me immediately when this lady tells me about her story is it's very easy immediately to think that this lady has stress. She's not eating well, she's not exercising, she's had previous surgery in that shoulder, and she's had a previous whiplash. You can see how easy it is to start trying to put that picture together. But as soon as your objective doesn't fit, so I can't reproduce things on the right side that correlate with those local symptoms. Similarly, nothing I do to her shoulder gives me any significant findings that are consistent with that pain distribution. But importantly, that the pain is so poorly localized, it's gnawing, and there's no mechanical picture. So no clear aggravating and easing factors. All those things should make you very vigilant. Then, as I say, hearing the history, family history of gallstones or any kind of gallbladder issues, again, is a risk factor. Often patients who have got mild cholecystitis may have a low-grade fever. They might report feeling a bit sick, and they might even get nausea and vomiting. What's interesting is that right shoulder pain, that poorly localized posterior pain, is not related to the severity. So if you've got shoulder pain, it doesn't mean that you've got a more severe problem with your gallbladder than those that just have localized pain. And interestingly, a significant proportion of pain can present with right shoulder pain as their first symptom of gallbladder involvement. They don't have to start with that right upper quadrant pain. Now, there is a test called Murphy's test, which is basically if you palpate just under the lower costal margin in that right upper quadrant space and just gently palpate and get the patient to breathe in. If they get rebound pain, then that's meant to be associated with gallbladder inflammation, but again, only in conjunction with all those other features that we've talked about. So this lady was really interesting, and obviously she came in there expecting me to do a bit of physio and get her doing some exercises for her shoulder, but obviously we had a very different conversation. But actually she kind of then started to say, well, yeah, I suppose sometimes I do feel a little bit sick, particularly if I have something greasy, if I have my eggs and bacon and whatever else. And obviously there's a whole lot of lifestyle factors that potentially I can broach with this lady. But importantly, I've got a strong suspicion that her right shoulder pain is actually a result of her gallbladder problem, and the key thing is to get her investigated by her doctor. Now, this lady was seen by her GP very, very quickly. She was given some diet advice, given some medication, 50% improvement in a 2-week period, but she did end up actually having her gallbladder removed and actually got in contact to say that her pain had almost gone completely. Now, one thing just to say is people having gallbladder surgery can actually develop right shoulder pain in the post-operative period, and that can actually last for up to about 8 weeks. It's associated clearly with the innervation relating to the surgery itself, but again, just something important. So I did say to this lady, if you end up having surgery, don't panic if the pain doesn't go straight away. It can last for a little while afterwards, but actually as the inflammation settles down, then actually you should find that all those things resolve. So guys, I know this is a bit kind of off-piste, but I think it's really nice to share some of these things. This is somebody that I just saw in a usual primary care video clinic with some very clear descriptors that clearly didn't fit in terms of a musculoskeletal issue, and just something to share with you to make us vigilant about these particular things. So just a short one for this evening to whet your appetite. Now, I will be back with more visceral cases, but I think we might do something a little bit different, a bit more rehabby next week, just to keep the physiotherapy aspects going. So if there's some key things you want me to talk about, do let me know. And I'm also very aware that I haven't yet answered one of the questions about vascular pathologies. So I'll find an interesting case study, somebody I've seen, because I always like to link things in. So yeah, we're getting all sorts of interesting comments about gallbladders, and thank you for whoever shared the correct spelling of ceftriaxone, which I could never pronounce, and rosapine, which is its generic grade. So guys, I hope you think you've taken something interesting away from that. I don't think there's anything else that I need to tell you, other than if you get somebody with poorly localized pain, particularly if it's described as deep, gnawing, or even knife-like, particularly if it's worse at night, and no mechanical aggravating or easing, and particularly when those lifestyle factors are associated, just bear in mind with right shoulder pain, the gallbladder is something you might want to consider. And importantly, those very simple questions in terms of, is there any relation to when people eat? And also, sorry, that's completely distracting me. Eric asking me questions about coracoid syndrome, which I'll come back to in just a second. Asking about the relationship with meals, but also what might seem a bit of an odd question, but also asking about stools in terms of, are they floating or not? Because again, that can just help complete that picture, but obviously it also validates it for the patient. So not everybody looks at those things, but if they have, it's an important part of the jigsaw. So guys, I really hope you've taken some interesting things for that, just to bear in your clinical reasoning when those features don't fit with an MSK mechanical thing. And as I say, I think it's also important when you have somebody like this who is overweight, doesn't exercise, admits themselves that they're really stressed, that we don't kind of write things off as just being due to psychosocial stress or overload in those other domains. We keep that detective snout going, if you like, and really search out those clues. Now, Eric's put a question, is there a coracoid syndrome? Well, Eric, it's really interesting. There's a couple of papers recently have talked about coracoid tenderness being pathognomonic for frozen shoulder. So we've talked quite a lot on the Facebook Live in the challenges of differentiating patients with a pseudo-stiff shoulder because of being scared about moving, and these neck shoulder pains that we're seeing a lot at the moment because of lots of people working at home, and that palpation tenderness over the coracoid that is more than tenderness elsewhere around the shoulder is thought to kind of help rule in a frozen shoulder, but we've only really got one paper looking at that. In terms of a true coracoid syndrome, there are also papers looking at coracoid impingement as a diagnosis. But again, I think it's very difficult when we look at our traditional impingement model that now has clearly been really challenged in terms of the traditional near model of this top-down model where you lost out on the genetic lottery, got born with a certain acromion, and then were more likely to develop an osteophyte and impinge the top of the cuff. We know that model just doesn't have any true support in the literature now, and it's much more a bottom-up model about the muscle system not doing its job. So in terms of somebody who's got coracoid tenderness, I think the bottom line, in somebody with non-traumatic or overuse pathology, we get best value from targeting the scapula, the cuff muscles, building those foundations, and then making sure our patients are strong enough to do what they do. So Eric, no doubt, if you look at the literature, you will find papers talking about coracoid impingement. You'll even find papers where they've chopped off the tip of the coracoid. To me, unless somebody's had a fracture where they've got extra bony growth there that is truly causing an issue, again, for me, it's more about the muscle system and targeting that than worrying about making a structural diagnosis. So I hope that helps answer that. Becky, I had a lady recently exactly the same, right upper quadrant pain, non-mechanical, right upper abdo pain, nausea. She had her gallbladder removed previously. I'd be intrigued to see if it's something relating to liver or otherwise. Oh, Becky, that's really interesting. Now, when you look at things like gynecological, and I don't know the answer to this, but certainly a question I will ask after that lovely comment, is that, again, we see ladies who have surgery. They have ovaries removed, they have gynecological surgery and can get a recurrence of symptoms because of scar tissue. I don't know if the same applies to the gallbladder, so that's something I definitely have to look into. But I like you thinking. I think the other thing you would definitely want to consider, particularly if she was better after her surgery but now has developed right upper quadrant pain, is definitely think about the liver. And that's certainly, I'll find a case study to present about something like that so I can tell you the key kind of questions to rule that in and out and in the future. Any link with coexisting gout symptoms? Alex, sorry, I'm not sure if that's in terms of the gallbladder. In terms of the risk factors, I would think that gout as a systemic pathology, maybe just in terms of general lifestyle. If you think of the links with gout, there's definitely some parallels with that gallbladder or cholecystitis group. It's not listed in most of the papers looking at the warning signs or the risk factors, if you like, in terms of developing gallstones, but I shall scribble that down and I will look that up for next time. Not in my list, if you like, in terms of the things that are flagged up, but I will definitely check that out for you and let you know on the next Facebook Live. Guys, as ever, I start with great intentions of doing a 10 or 15 minute, and then you ask me all these fabulous questions, and it's just rude not to answer. So I've answered Eric. I've answered Becky. So Becky, that would be an interesting one. As I say, if she was better after her surgery and then it's come back, I guess I'd be thinking, can we get scar tissue after surgery? And again, I'm going to look that up as well. And in terms of the gout, again, in terms of those lifestyle factors, it's definitely one I'll look into, but not in the papers that I've read. But that doesn't mean it's not out there, so I will double check. Guys, thank you. I love it when I get questions. It makes it really fun. And I've certainly been doing a lot of looking up and researching in response to some of the questions we've had over the last few weeks. But that's what makes it fun and means we all keep on learning. So, guys, a short one tonight. Thanks as ever for joining. I hope you found that case study really interesting. I'll look forward to being here next Monday with some more interesting things. As I think I'm probably going to look at something a little bit more rehab based next week, just to mix it around a knot. And I'll look forward to hearing from Becky about her lady who's going for investigations. And it's great to learn from your practice as well. So thank you so much for sharing your experiences too. I'll look forward to seeing you next Monday. But for now, I will leave you to your Monday night, and I'll very much look forward to some more shoulder geeking very soon. Bye for now.